Hello. So for our CLC assessment, we'll be focusing on the lower extremity. My name's Eliana.
I'm Brianna.
And I'm Aliana. So in this scenario, we'll be looking at a 21-year-old female who is a physical therapy technician, and she's experiencing knee pain. So for this assessment, we have this patient who comes in, and the first step is to do a health risk appraisal. So this will give information as far as any limitations that will cause the client to not partake in physical activity. So in this example, overall, I would consider this an example where she would be eligible to perform an physical activity. We would just take a little precaution due to the minor chest pain and dizziness that she experiences. But overall, the purpose of this Part Q is to rule out any cardiorespiratory or chronic illnesses that would limit somebody with a given exercise program. So here with our medical history, again, so this is going to provide important information about any life-threatening diseases or things that would limit somebody's ability to perform a given movement. So in this example here, she noted that there was presentable concussions and ankle sprains due to competing in a sport. So in this example, basketball. It's important to note that we need to take this into consideration in order to provide a safe and personalized exercise program. And it should be noted that no surgeries or any major medical concerns are a good step forward to making a good plan for her. And this can kind of be an indicator as well for the practitioner of any future injuries as far as the ankle sprains. It can affect the whole kinetic chain. So you can see discrepancies within the knee all the way up to the lumbopelvic hip complex and even the upper extremity.
As for the recreational and occupational history of the individual, we're going to be looking at the fact that she does do hiking and she plays basketball and yoga as her recreational physical activities. These can help create in the creation of the program, as they can help it become more curated for the individual so that they will want to come back and do the exercise. As for the additional hobbies, it is clearly stated that she likes to read and paint, and these let the professional know that she could be in positions that could affect her some muscle imbalances. So it helps us know that there's habitual repeated movements that could be leading to the impairments. As for her occupation, it is stated that she is a physical therapy technician. So with this occupation, there's going to be a significant amount of squatting and lifting that's going to be occurring, which could lead to kinetic chain dysfunctions and muscle imbalances that we will then go over. Okay. So as for the static postural analysis, we're going to be discovering the standing position that an individual is in before movement occurs. So this can be just the position that an individual is in when they are standing in a resting position. So for the normal findings that we found, we can see that her pelvis is level with both posterior superior iliac spines in the same transverse plane. It can be seen that her head is in a neutral position and it's neither tilted nor rotated. As for the abnormalities, we can see that her foot is exhibiting a significant amount of flattening, and that can be due to the overactivity of muscles such as the peroneal complex, lateral gastroc, biceps femoris, and the TFL. As for the underactivity muscles, we're going to be looking at the anterior tibialis, posterior tibialis, medial gastroc, and glute medius. Her knees can also be exhibiting adduction, so they move inward, causing a valgus motion. This can be due to the overactivity of the adductor complex, biceps femoris, TFL, and the underactivity of the muscles of the medial hamstring, medial gastroc, and glute medius and maximus. As for her shoulders, you can be seeing that it is rounded, and that is due to the overactivity of the pecs, pulling her shoulders forward, and the underactivity of the mid and lower traps. As for the lateral view, it can be seen that the abnormalities that are seen are at the lumbar pelvic hip complex, which can be seen a little bit posteriorly rotated to the left. So it's due to the overactivity of the external obliques, adductor complex, and hamstrings, and underactivity of the glute med and max, as well as the intrinsic core stabilizers. As for the shoulders, we can again see that they are excessively rounded due to the overactivity of the pecs and underactivity of the mid and lower traps. As for the normal findings, we can see that her foot and ankle are in a neutral position. You can see that the leg is vertical to the right angle of the sole of the foot. Her knees are normal. There's no hyper extension or flexion of the knee. And her head is not in an excessive extension phase, so it's not jutting forward. As for the posterior view, it is very similar to the anterior view. Her pelvis is level with her PIS in the same transverse plane, and her head is in a neutral position. It's neither tilted nor rotated. As for the foot, again, there is flattening of the foot. Her knees are adducted again. However, it is different in the sense that we can see her scaps and the level of her scaps. So this can be due to poor posture, favoring of a certain side, or due to the fact that she might favor a side that is making it lean more in this case, we can see that it is more of a right lean. So it's slightly elevated and is protracted forward a little bit, leading to the overactivity of the upper traps, levator scap, pec major and minor, and the underactivity of the lower traps, lower serratus anterior, and rhomboids.
So for transitional movement assessment, the overhead squat, this in particular, it's a great way to assess any human movement system impairment as the movement's occurring without a change in one's base of support. And with this specific assessment, it's reliable and valid in being able to measure any lower extremity movement patterns when the proper standards and protocols are in place. And we won't actually play this video just because you can see the individual or the client's face in it. So for privacy reasons, we won't play it, but we do have images on our next slides. Okay, so here for the anterior view, you can see that something that's normal is the knees do not move inward, but as for the abnormalities, the feet do flatten, the feet turn outwards, and the knees move outwards as well. So the feet flattening is caused by the overactive muscles which are listed. And as a whole, these kind of deal more with plantar flexion, knee flexion, hip internal rotation. And for the feet turning outward, the overactive muscles which are listed mainly involve plantar flexion as well, knee flexion, and tibial external rotation. The knees moving outward, those overactive muscles listed primarily focus on hip external rotation and abduction and tibial external rotation, which is what causes the knees moving outward. The kinetic chain checkpoints to look for at the anterior view are the foot and ankle and the knee. For the lateral view, some things that are normal here are the client does not have a lower back which arches, the lower back does not round, and the arms do not fall forward. But for an abnormality, you can see that there's an excessive forward lean. So this can be caused by overactive muscles, which primarily deal with plantar flexion, hip flexion, and external rotation and spinal flexion. The kinetic chain checkpoints to look for here are primarily focusing on the lumbopelvic hip complex, the shoulders, and head/cervical spine, which is like focusing on the upper body. And then for the posterior view of the overhead squat, the things which are normal here, the heels do not raise off the floor. There are no asymmetrical weight shifts, but for an abnormality, the feet do flatten similar to how you can see it in the anterior view. And again, the overactive muscles that cause this primarily deal with plantar flexion, knee flexion, and hip internal rotation. The kinetic chain checkpoints to look for here are the foot and ankle. And for every view of this, the anterior, lateral, and posterior, the underactive muscles kind of work against whatever the overactive muscles are doing. But in them being underactive, that's why you see the feet flattening, you see the knees going outward, etc. So here for our next transitional movement assessment, we have the single leg squat. And for a similar reason to the other video, we won't play it due to you being able to see the individual's face in it. But this assessment is also just as reliable and valid as the previous one in measuring the lower extremity movement patterns when the standard protocols are in place. So for here, it's only an anterior view that you can view that we viewed this from. But for some things that are normal, you can see that the hip does not hike, the torso does not rotate outward. But for abnormalities, the knees move inward, the hips drop, and the torso rotates inward as well. So for the overactive muscles, the knees moving inward, these primarily as a whole focus on hip adduction, knee extension, plantar flexion, hip flexion, and hip internal rotation, thus causing the knees to kind of move more inward. The hips dropping, the muscles here kind of, the overactive muscles focus more on hip adduction as well, causing the hips to drop. The torso rotating inward, the overactive muscles listed primarily focus on lateral flexion, hip adduction, hip flexion, and hip internal rotation on the stance leg, and ipsilateral rotation on the opposing leg. Some kinetic chain checkpoints here to focus on are the knee and the lumbopelvic hip complex. And like I mentioned earlier, all the underactive muscles kind of work against what the overactive ones are doing. So in them being underactive, that's what allows overactive muscles to have more control, thus causing the knees to move inward, the hip dropping, and the torso rotating inward as well.
As for the gait analysis, we can see that the normal findings, there was no inward of the knees, so there was no valgus. As for the abnormalities, again, we can see that there was feet flattening. So again, the overactive muscles of the peroneal complex, lateral gastroc, and underactive are anterior and posterior tibialis. As for the lateral view, we can see that her lower back stays neutral. There was no low back arch. Her head does not migrate forward. As for the abnormalities, again, we see that her shoulders are excessively rounded. This can be due to the overactivity on the muscles such as the pecs and the lats pulling the shoulders down, and the underactivity of the mid and lower traps and the rotator cuff. In the posterior view, we can see that there was no excessive pelvic rotation. The hip did not hike. However, again, we can see that the feet were flattening on this view.
So for here, the range of motion in general, kind of as it suggests, assesses the range of motion of a particular joint. And in this case, we focused on two tests, which kind of had some correlation to the compensations that we could see within the transitional movement assessments. So for the first one here, we have ankle dorsiflexion. And for the placement of the goniometer, you have the axis directly below the lateral malleolus near the base of the foot. The stationary arm is on the lateral aspect of the fibula, and the mobile arm is on the midline of the fifth metatarsal. And you kind of just have the client's foot at a 90-degree angle and then have them dorsiflect as far back as they can. Here you can see on the right foot, the client got 15 degrees, and on the left foot, it's 11. The normal for this is typically 20, so there's some decreased range of motion there on both feet. The muscles assessed here, which might have to do with decreased range of motion, include gastroc, the soleus, posterior tibialis, etc. They may be overactive, and the antagonists, which could be underactive, include the anterior tib, extensor digitorum longus, etc. And for knee extension, the placement of the goniometer is with the axis on the lateral joint line of the tibial-femoral joint, the stationary arm on the lateral midline of the femur, and the mobile arm on the lateral midline of the fibula. And here on the right foot, the client got 20 degrees, which is normal. And on the left leg, it's 10 degrees, which is slightly decreased range of motion. And this may be because of overactive muscles such as the hamstring complex or the gastroc. And the antagonists, which may be underactive here, causing decreased range of motion, include the hip flexor complex and the quadricep complex. So here we also assessed the strength of a few of the muscles. So in this instance, we heard a lot about the gluteal complex as well as the anterior tibialis being one of the more underactive muscles present in a lot of the dynamic and static assessments. So here, manual muscle testing is a very time efficient and overall productive mechanism to determine somebody's strength, especially something that a lot of practitioners practice. So in this example here, we'll go off of the grading system first. So this is all determined by the client's ability to withstand resistance that the practitioner places on a given area. So in this instance here, 3 would be considered normal, 2 will be the compensations, which I'll explain in the 2 manual muscle testing provided, and weak would indicate that the person or client is unable to do the movement itself. So here we have the glute max. It'll begin with the patient lying prone. The practitioner here will place one hand on the lower leg and also one on the hip to maintain stabilization of that given area. So here, what's going to happen is the practitioner is going to place pressure in the direction of hip flexion, adduction, and internal rotation. Typically, this is also referred to as a break test, in which the practitioner will place gradual pressure on a given area and will ask the client to hold that position for about 4 seconds. If the person is unable to do the movement, such as in the glute max, this will often indicate compensations such as tight hip flexors and things like that. As far as the anterior tibialis, here, this is also going to provide information about determining one's neuromuscular efficiency. So in this instance here, the client will lie supine with the knee extended. The ankle is going to be placed in plantar flexion and inversion. So what the practitioner is going to do is apply gradual pressure to the medial plantar surface of the foot, which will then be in the directions of dorsiflexion and eversion. So things to note that would grade that manual muscle test of 2 is if you notice a lot of pointing of the toes as well as bending of the knee. Next here is just an additional assessment that might be very informative to understand the client's impairments. So this is going to be the LAN error scoring system, in which a person will be placed on a higher platform and they'll be asked to jump about half their height to the floor. And in this instance, you're going to determine if there's any impairments such as knee valgus, which is prevalent in this example here. And they'll also be asked to do an explosive jump up after they had landed from the prior jump from the box. So here in this example, there's excessive knee valgus, which can determine, again, a lot of weakness in muscles such as the anterior tibialis, glute med, and glute max, and overall the hamstring complex. Here again is going to be looking at the feet as well. Starting from that landing position with inverted feet already causes a lot of other gradual impairments that are going to occur from the knee to the hip. So again, here you're going to notice a lot of overactive muscles such as the adductor complex, the biceps femoris, and the TFL. So here in the next slide, we're also going to demonstrate the scoring system. So for this test, it is off of a 19-point grading scale. The higher you score, the more increased risk for injury is going to be more prevalent. This would often allude to the practitioner that you need a specific training that targets those impairments. So based off of the client's score, this is going to be a total score of 7. Overall, it's just looking at the initial contact of the landing phase, as well as looking at the whole chain, as far as like feet, ankle to the trunk, as well as comparing it to shoulder width, for an example here of the initial contact phase. And this would often indicate, again, the potential for more injury, which is why a specific individualized program needs to be implemented for the client. And here are references. Thank you.